Welcome everyone to The Explainer. I'm acting as your coding instructor today to decode the highly specific, and let's be honest, sometimes complex, billing guidelines for remote patient monitoring. If you've been working with CPT codes for evaluation and management, you know that the landscape of digital health and remote care has absolutely exploded. We've got a lot of detailed CPT rules to cover today, specifically focusing on codes 99453 through 99458. As well as the 98975 through 98981 series. My goal today is to give you total clarity on these guidelines so you can capture the right revenue while staying perfectly compliant.
Today, we're covering RPM versus RTM fundamentals, initial setup and education, device supply rules, treatment management, and finally, supervision and audits.
Part 1, RPM versus RTM fundamentals.
First up, we've got remote physiologic monitoring, or RPM. RPM is all about automated physiologic data. We're talking hard, objective vital signs like blood pressure, weight, pulse ox, or blood glucose. But here's the absolute kicker, straight from the CPT guidelines. This data must be collected and transmitted strictly by an FDA-cleared medical device. The device has to do the heavy lifting, gathering that physiologic data and sending it straight to the provider. Now, remote therapeutic monitoring, or RTM, is a totally different ballgame. It's designed for non-physiological therapeutic data, and here's the major distinction you need to remember. While RPM demands automated data collection by an FDA-cleared device, RTM actually allows data to be self-reported or digitally uploaded right by the patient. Let's put them side by side. RPM gives us those hard vitals, but RTM focuses on completely different metrics, like a patient's respiratory status, their musculoskeletal or MSK status, therapy adherence, and even cognitive behavioral therapy. Basically, if you're tracking a patient's pain levels or keeping tabs on how well they're sticking to a medication regimen, you're definitely operating in the RTM space.
Moving on to Part 2, Initial Setup and Education.
All right, before we monitor anyone, we gotta get the equipment out there. Whether you're using the RPM setup code 99453 or the RTM setup code 98975, there are 3 distinct steps you have to complete to bill for the setup. You need to handle the initial device delivery physically or digitally, facilitate the actual setup, and provide comprehensive patient education and training on how to use the equipment. You can't just hand a patient a cardboard box and build a code. That education piece, absolutely mandatory.
And here is a crucial point right from the CPT guidelines. For code 99453, you can only build these setup codes once per episode of care. The guidelines define an episode of care as starting when the monitoring service is initiated and ending when the targeted treatment goals are met. So no way can you build the setup code multiple times for the same device during a single episode. It's a one-and-done deal per episode.
Part 3, Device Supply and Transmission Rules.
I need you to lock this number into your brain right now, 16. For the RPM device supply code CPT 99454, you must have automated data transmission for at least 16 days within a 30-day period. The CPT book is incredibly strict about this. Seriously, if you only collect 15 days of data in that 30-day window, you cannot report 99454. It's a hard, non-negotiable minimum threshold to prove that consistent monitoring is actually happening.
Now, while RPM just uses a single supply code, RTM gets a lot more specific. RTM supply codes are neatly categorized by organ system or therapy type. You've got to make sure you choose the code that precisely matches the targeted therapy. Code 98976 is exclusively for respiratory status, 9897 is for musculoskeletal status, and 98978 covers cognitive behavioral therapy. Picking the right code makes sure your claim tells the true clinical story. Plus, it keeps the auditors from knocking on your clinic's front door.
Moving to Part 4, Treatment Management and Communication.
This breakdown is basically your playbook for management time in a single calendar month. Notice that these are time-based codes. For RPM, your base code for the first 20 minutes of management is 99457. Then you can stack the add-on code 99458 for each additional 20 minutes. Over on the RTM side, you use 98980 for the first 20 minutes and 98981 for each additional 20. The golden rule here? You always start with your base 20-minute code before you even think about stacking on those extras.
But here's where clinics frequently run into trouble. We know we need 20 minutes of total clinical staff or provider time during the calendar month, but what actually satisfies the interactive communication standard required for these base codes? Like, is a quick text message enough? What about a nicely worded email?
Well, the CPT guidelines are crystal clear on this. Code 99457 requires at least one real-time interactive communication with the patient or caregiver during that calendar month. And real-time literally means a synchronous audio or video interaction. Sending chart notes or written exchanges that are just sitting in the patient portal, that does not qualify as an interactive exchange. You need that live conversation to fulfill the criteria, and yes, that communication time does contribute to your total 20-minute threshold.
Finally, Part 5, Supervision and Compliance Audits.
Let's talk about staff utilization. Both RPM and RTM treatment management codes are fantastic because they actually allow clinical staff, we're talking nurses or medical assistants, to perform these services. But there's a catch. If clinical staff are doing the work, it has to be under the general supervision of the billing physician or qualified healthcare professional. So the physician oversees the whole program and manages the specific treatment plan, while the clinical staff can handle the day-to-day data review and those interactive communications we just talked about.
Now, listen up, because this is a massive audit red flag. The CPT guidelines explicitly state that time spent performing RPM or RTM services must remain entirely separate from other care management services. This is especially vital when you're dealing with a patient who's also enrolled in chronic care management, CCM code 99490, or transitional care management. You have got to strictly carve out your time. No single minute can be counted twice across different care management programs. It's just not allowed. If you spend 20 minutes discussing RPM data, that 20 minutes belongs exclusively to code 99457. You can't turn around and use that same 20 minutes to try and hit your threshold for CCM code 99490. Your documentation must clearly, unmistakably delineate which minutes belong to which service if you want to survive an audit. And with those compliance rules locked in, you are fully equipped to accurately set up, monitor, and bill for both physiological and therapeutic remote monitoring. Remember, keep your device days at 16, ensure your interactive communication is truly real-time, and absolutely never double count your minutes. So ask yourself, are you leaving legitimate revenue on the table just because your clinical team is afraid of these documentation rules? Equip them with this knowledge and turn compliance into a tool for better patient care. Don't forget to like, share, and subscribe to Decode Healthcare with Harshal.